Welcome to Dr. Manny's YouTube Learn Shops. In this presentation, we're going to cover acute respiratory failure and ARDS, Acute Respiratory Distress Syndrome. First of all, what's respiratory failure? Respiratory failure is exactly that, failure to breathe. It's a medical condition which your blood doesn't have enough oxygen, hypoxia, hypoxemia, better term, or has too much carbon dioxide, hypercapnia, hypercarbnia. And sometimes you can have both problems, not enough oxygen or too much carbon dioxide. So if we define respiratory failure is another syndrome in which the respiratory system fails one or both of its gas exchange functions, oxygenation and elimination of carbon dioxide. In practice, however, it may be classified as either hypoxemia or hypoxic, or hypercapnic or hypercarbic. And basically, as the diagram indicates, respiratory failure is lung failure or pump failure. Lung failure is gas exchange, or pump failure is ventilation. So what are the types of respiratory failure? You've got two types, type 1 and type 2. Type 1 respiratory failure is failure to get enough oxygen, hypoxemic. And if you do an arterial blood gas, the PaO2 will typically be less than 60 millimeters of mercury on 60% oxygen. And this can be acute, which is sudden, minutes to hours, or it can be chronic, which can be days, weeks, months, even years. Hypercapnic or hypercarbic is you're not able to breathe properly and get rid of CO2. Ventilatory failure, pump failure. And typically this is now where your PaCO2 from your arterial blood gas is greater than 45 millimeters of mercury and your pH is less than 7.35. This can also be acute, minutes to hours, or chronic, days, weeks, or longer. What are the causes of type 1 hypoxemic? This can be COPD, chronic obstructive pulmonary disease such as emphysema or chronic bronchiolitis, pneumonia, pulmonary edema, pulmonary fibrosis, asthma, pneumothorax, pulmonary embolism, pulmonary arterial hypertension, certain disorders, congenital problems, acute respiratory distress syndrome, ARDS, which we're going to cover, mechanical problems to do with kyphosis or scoliosis, and just obesity. But this is to do with now gas exchange. And sometimes type 1 and type 2 can be interrelated. Type 1 classification, as we said, is indicated by a PaO2 of less than 60 millimeters of mercury on fairly high oxygen concentrations. And it's the most common form of respiratory failure, and it's associated with virtually all acute lung diseases, which involve the alveoli. Examples of type 1 respiratory failure, as we mentioned previously, can be cardiogenic, related to the heart, or non-cardiogenic, which can be purely related to the lungs. Here are some examples of type 1, cystic fibrosis, foreign body airway obstruction, atelectasis or lung collapse, trauma. I mean, we've got a fractured right clavicle there, and fractured ribs, 1, 2, 3, 4, 5 posterior fractured ribs. Pneumonia, right middle lobe. Tuberculosis, fibrotic lung disease. Congestive heart failure, related to both right and left heart failure. Pulmonary edema, wet lungs, alveoli full of fluid. Scoliosis, thoracic mechanical problems, and he even has a tracheostomy. Pulmonary edema again can have an effect on gas exchange and getting rid of CO2. Acute Respiratory Distress Syndrome. Look at those lungs. They're all white, full of fluid, collapsed, atelectasis. Chronic obstructive airway disease, chronic obstructive pulmonary disease, chronic obstructive lung disease, whatever terminology that you would like to use. These are patients like emphysema patients, chronic bronchiolitis, bronchiectasis. They can't get rid of CO2. So the classification, according to type 2, is that the CO2 or the PaCO2 is higher than 50 millimetres of mercury. Look, hypoxemia is common as well. Common etiologies could be drug overdose, like sedatives, opioids, neuromuscular disease, chest wall anomalies like kyphoscoliosis, severe airway disorders, asthma, chronic obstructive pulmonary disease, emphysema, bronchiolitis, bronchiectasis. The list goes on. They cannot get rid of CO2, but they can be hypoxic as well. Then, respiratory failure can be classified accordingly as far as acute and chronic. Acute, sudden, chronic, longer term. Now, when it comes to acute and chronic classifications, they are usually made on the basis of the arterial blood gases, because the blood gases can indicate pH, PaCO2, PaO2. And it's important that they are evaluated. So blood gases should be evaluated. Chest X-ray is essential. Pulmonary function tests can be done as well. And ECG is typically done to eliminate cardiac problems that may cause the respiratory failure. When it comes to the pathophysiology, the main issues are type 1 is gas exchange, oxygen. 2, CO2 is type 2. But the main issues in respiratory failure are you've got a gas exchange problem and you've got what is called a ventilation perfusion mismatch, which basically means if you've got lung collapse, air can't get in, but blood is flowing through the pulmonary capillaries. There's a mismatch, which is often referred to as a shunt. When it comes to the clinical presentation, the diagnosis is confirmed by the arterial blood gases. They will give a picture of whether it's acute or whether it's chronic. And we'll review blood gases in one of the presentations in the Dr. Manny Learn Shops. When it comes to the clinical presentation and the physical examination, there'll be a tachycardia, there'll be tachypnea, there'll be dyspnea, accessory muscle use, maybe confusion, maybe somnolence, meaning here that there may be changes in the level of consciousness. They may have an asterixis, which again you can see in the picture there here, which is a finger flap. They may have cor pulmonale, which basically means right heart failure, and in the worst possible scenario, they may be cyanized. When it comes to the diagnosis, always important, history and physical assessment. Diagnostic tests can include pulse oximetry, SpO2, arterial blood gases, electrocardiogram, ECG, chest x-ray, pulmonary function tests. What are the management options? Well, it depends on whether it's acute or chronic and whether the disease is severe and what caused the disease. But generic treatments may include oxygen therapy, intubation and mechanical ventilation, a tracheostomy, non-invasive mechanical ventilation, continuous positive airway pressure ventilation, positive airway pressure ventilation, maybe giving fluids and maybe giving certain medications. What's the medical management? Well, in the medical management, it's important for the physician to identify and treat the cause. And always remember, ABC or CAB. Maintain and protect the airway. Oxygen therapy, always cautious with COPD patients. Hydration, bronchodilators, mucolytics, arterial blood gas analysis, maybe intubation and mechanical ventilation. Mechanical ventilation can be invasive or non-invasive. The nursing management basically means we follow the physician's orders. If they're ordered antibiotics, bronchodilators or diuretics, they are given as prescribed. We monitor the patient's vital signs, especially the respiratory status, arterial blood gas analysis, and whether they're responding to the medical interventions. And it's our role to report and document positive and negative outcomes. And always, basic care, mouth, eye, skin, the ultimate goal is to prevent also pressure ulcers. When it comes to the prognosis, well, again, it depends on whether it's acute or chronic, but mortality rates in relation to other conditions, if you've got comorbidities, then here a lot of the conditions are obviously not evidence-based, but acute exacerbation still carries a mortality of around about 30%. But prognosis overall with acute can be very, very, very good. 10 to 26% mortality. Now let's look at acute respiratory distress syndrome. An ARDS is a life-threatening lung injury that allows fluid to leak into the lungs from the pulmonary capillaries. In essence here, it's a pulmonary edema, not a cardiogenic pulmonary edema caused by heart failure. And with this acute lung injury, it's unresponsive to conventional oxygen therapy. And there's a sudden and progressive pulmonary edema, hypoxemia, reduced lung compliance, and increased infiltrates on chest x-ray. And it always requires intubation and mechanical ventilation and transfer to the intensive care. What's the pathophysiology? Well, something causes inflammatory response, something. And it initiates cellular and mechanical and chemical mediators. And it injures the alveoli capillary membrane, which results in leakage of fluid into the alveolar interstitial spaces and the alveoli. And it creates a ventilation perfusion mismatch, which means if the lungs are full of fluid, air can't get in, blood can still flow by, but the capillaries leak. They leak plasma. The alveoli collapse, bronchospasm, obstruction, and the lungs become stiff and non-compliant, and overall there's hypoxemia, which is unresponsive to oxygen therapy. Here are some examples of the ARDS chest x-ray. Look at A, that's the normal. Then there's progression. See, you're getting increased whiteness, congestion in the lungs. C, more whiteness, less blackness. Blackness is air. And D, eventually, stiff, non-compliant lungs that have collapsed, alveoli collapsed and full of fluid. Okay, what's the etiology of acute respiratory distress syndrome? And there are many, many, many causes, many. Aspiration, and aspiration can be gastrointestinal regurgitation and aspiration. It can be salt water, fresh water, drowning. It can be ingestion of certain medications, hematological disorders, high concentration oxygen, smoke inhalation, or corrosive substances, even heat. You can be in a room here now where you've got very, very high temperatures, a burning room, and you can inhale the hot air, and that can cause problems. Localized infection or systemic sepsis, metabolic disorders, shock, trauma, and major surgery. So, when we come to the causes, they can be direct or indirect. Direct causes can be directly in the lung, bacteria, viruses, fungi, parasites. Aspiration of gastric contents, or even here, aspiration of salt water, fresh water, near drowning. Air or fat emboli, even here, thrombi, pulmonary embolism. Toxic inhalation of certain gases, smoke, or injuries like lung contusion. And certainly after a lung transplant or a thrombectomy of the lung or certain procedures in the lung, ARDS can occur as a result of direct lung injury. Indirect means coming from somewhere else. So this can be coming from septic shock, multiple trauma, pancreatitis, massive blood transfusions, transfusion-related acute lung injury, TRALI, drug toxicity, neurogenic pulmonary edema, and cardiopulmonary bypass. But it's coming from somewhere other than the lung, indirect lung injury. What are some of the clinical manifestations? Well, the clinical manifestations are severe respiratory distress, dyspnea. They're hypoxemic, unresponsive to oxygen therapy. On the chest X-ray, have a look, second chest X-ray, bilateral infiltrates fluid on the chest X-ray. Increased alveolar dead space, which means areas of lung that cannot participate in gas exchange. VQ mismatch, ventilation perfusion, same again. Gas exchange can't occur. And you end up with stiff, non-compliant lungs that are very difficult to ventilate. When it comes to assessment and diagnostics, history and physical assessment are really important, but there are no specific tests that can be done that identify ARDS. Diagnosis is primarily based on physical examination, the chest X-ray, the oxygen levels, and this is important to rule out other diseases or conditions, because again, certain heart conditions can produce similar signs and symptoms. What's the medical management? Well, typically intubation, mechanical ventilation, fluid support, feed them effectively, supplemental oxygen, still monitor the arterial blood gases, provide positive end expiratory pressure, PEEP, with the ventilator, vasodilators, corticosteroids, and surfactant replacement therapy. Many of these things may work, but often don't work, and could be considered sometimes here experimental. Nursing management, well again they have to be admitted to the intensive care. We support them, we follow the physician's orders, we monitor them closely, and we always maintain their airway, hydration, frequent turning to prevent pressure ulcers, and we implement whatever medical plan the intensive care physician recommends. So what's the prognosis? The prognosis is still pretty high. But again, the mortality rates depend on what potentially caused the ARDS. So let's review briefly. Name two types of respiratory failure, type 1 and type 2. Type 1, hypoxemic. Type 2, hypercapnic or hypercarbic. Name the causes of respiratory failure following in the diagram. Well, again, what we've got there is hypoxemic can be caused by the following. Hypercapnic can be caused by them. But sometimes they are combined and interrelated. 4 clinical signs of early stages of ARDS will be restlessness, confusion, level of consciousness changes, shortness of breath, hypotension, maybe a cough, maybe a fever if it's related to a septic problem. But usually the chest X-ray is normal for the first 72 hours and the patient is unwell. This is early. So therefore, in the first 48 hours to 72 hours, usually the clinical signs are bad, but the X-ray signs are good. After 48 hours, things become worse. Their clinical signs and symptoms become worse, and their chest X-ray becomes very, very bad, very abnormal. Thanks again for your interest in this Dr. Manny Learn Shop. If you think this has been of any benefit to you, please recommend it to your colleagues and friends and subscribe. And I'll see you in other Dr. Manny Learn Shops if you think they're of any value to you. Take care and God bless.